All right, let's talk about diagnosing menopause. We're going to break this down into a super high-yield guide that'll make you feel confident whether you're on your OB/GYN rotation or just cramming for step 2. Okay, let's get right into it.
So let's start with a classic case you'll see a million times. You've got a 49-year-old patient. She comes in complaining of hot flashes and says she hasn't had her period in 9 months. What do? What's your very next step? Do you order an FSH? Do you start talking about hormone therapy? By the end of this, the answer is going to be second nature.
But before we can even answer that, we have to make sure we're all on the same page with our definitions. When it comes to menopause, honestly, timing is everything.
So here's the official textbook definition. Menopause is the permanent end of menstruation. But the key word, the one you absolutely have to remember, is retrospectively. You can't actually make the call until a full 12 months have gone by without a single period.
And when does this usually go down? Well, the median age for natural menopause is right around 51.4 years. Just keep that number in the back of your mind. It's a great anchor point when you're evaluating a patient.
Now here's where it gets really interesting and clinically super important. It's all about how we categorize it by age. If menopause happens between 40 and 45, we just call that early menopause. But if it happens before age 40, that's a totally different ballgame. That's primary ovarian insufficiency, or POI. And it's a critical distinction because POI needs a whole different workup to figure out what's going on underneath.
This timeline here just lays it all out perfectly. You've got a woman entering what we call the menopausal transition. You might also hear it called perimenopause. Then she has her final menstrual period, the FMP, and that's when the clock starts ticking. Only after that full 12-month wait with zero bleeding can you officially stamp the chart with the diagnosis of menopause. So, that covers the what and the when. Now let's get to the why. What's actually happening inside the body to make all this happen? The easiest way to think about it is like a programmed ovarian burnout.
And this is exactly what I mean. From the moment someone is born, the number of follicles in their ovaries is on a steady decline. But look at how that curve just nosedives around the late 30s and early 40s. It leads to this near total exhaustion of follicles. And that, right there, is the fundamental engine driving menopause.
So what happens when those follicles disappear? Well, it sets off this whole hormonal cascade. Fewer follicles means they're making less of a hormone called Inhibin B. And without Inhibin B telling the pituitary to chill out, the negative feedback is lost. So what does the pituitary do? It starts screaming. It pumps out more and more follicle-stimulating hormone, or FSH. That rising FSH, that's the cardinal sign of reproductive aging.
But here's the thing. It's not a smooth, clean process. Just look at this graph of the transition period. See how FSH is on that steady upward climb? Now look at the estradiol. It's absolute chaos. It's spiking, it's crashing, it's all over the place. And this hormonal chaos is exactly why patient symptoms can be so unpredictable. And more importantly, it's why checking a single random FSH level during this time is totally useless. It can be completely misleading. We're going to come back to that point because it's the key to our whole diagnostic algorithm.
Okay, so we've got the physiology down. Now let's connect the dots to what the patient is actually feeling. What are the core clinical features they're going to come in and tell you about?
The very first thing that usually shows up is menstrual irregularity. We're talking a change of more than 7 days in how long her cycle is. Then you get the classic stuff: vasomotor symptoms, VMS, which are your hot flashes, genitourinary syndrome of menopause, GSM, a lot of sleep disturbance, which is often tied to night sweats, and of course, mood changes.
Now listen, it is absolutely critical that you know the difference between VMS and GSM when you're counseling your patients. Hot flashes, they're super common, affecting up to 80% of women, but they usually get better over time. GSM, on the other hand, that's things like vaginal dryness, painful intercourse, that is progressive. It does not resolve on its own. It will only get worse without treatment, and that makes a huge difference in how we manage it.
Okay, so this brings us to the highest yield part of this whole talk. The practical, step-by-step diagnostic algorithm you can literally use in clinic tomorrow.
Let's go all the way back to our first question. You're faced with a patient, she's got the symptoms, how do you make the right call?
You know what? The answer is way simpler than you'd think. Your entire approach, your whole thought process, is driven by one simple question. How old is the patient? Let's break this down by age group.
So for women over the age of 45, this is key. If she comes in with those typical irregular periods and classic hot flashes, the diagnosis is clinical, period. You don't need to order any labs. I'm going to say that again because it's so important. ordering an FSH in this patient is unnecessary. In fact, because of those wild hormonal swings we saw, it can actually be misleading.
Now, for the 40 to 45 crowd, we've got to be a little more careful. Yeah, it's probably the menopausal transition starting, but we have to rule out other common things that cause irregular periods. So for this group, you're going to order a beta-HCG to rule out pregnancy, a TSH for thyroid issues, and a prolactin level.
And finally, if your patient is under 40, that's a red flag. You have to suspect primary ovarian insufficiency. And in this specific situation, and only this one really, a full workup that includes a serum FSH level is absolutely required to make the diagnosis. See, age is everything.
All right, let's wrap this all up. Let's summarize the most critical, must-know points that are going to stick with you for your exams and, more importantly, for your actual practice.
If you remember one thing from this entire talk, let it be this mantra. Treat the patient, not the FSH. Especially for those women over 45, your clinical brain and their story are so much more valuable than some random lab number.
So let's do a lightning round recap. 1. The diagnosis is always retrospective, after 12 months of no periods. 2. If she's over 45 with classic symptoms, it's a clinical diagnosis, no labs needed. 3. Because of that hormonal chaos, FSH is totally unreliable for diagnosis during the transition. And 4. Always, always, always rule out pregnancy. So, back to our 49-year-old with 9 months of amenorrhea, the next step is simply clinical follow-up and counseling. You've diagnosed her as being in the menopausal transition. And now the real conversation begins. How are you going to help manage her symptoms?